So what we're going to look at today is knee pain and orthoses. So now, knee pain is a massive subject. There's loads of different treatment modalities for it. There's tons of research, and obviously we've only got sort of 35-45 minutes. So it's a bit of an overview. We're going to talk a lot about research. We'll be looking at the research with orthoses and different things you can do. The main objective is that you take something away from it and it just sort of inspires you to look a little bit further into it. Now, my disclaimer to start with is that I haven't written up the reference slide for the simple reason it just takes me forever. But having said that, if there's any references that you would like, then jot them down as we go through and then email me or email LBG Medical and I can send them to you, or any other papers that might be of interest. If you haven't got time to jot them down during this, you do get an email at the end of the webinar. And that will give you the opportunity to re-watch it. So then you can re-watch it and you can press pause and stuff like that to sort of catch up and watch it slower. There is also a 30-second delay on this. So what I'm saying then takes 30 seconds for you to hear it as well, which shouldn't affect anything. And then I would ask as well, you do all questions and answers at the end, and then I can read them out and give you answers. So. Okay, so the aims of today are to look at the different types of knee pain. We can have a look at some of the mechanical or the biomechanical origins or things that might be causing it. We'll look at the pathomechanics, and I've got quite a lot of slides on orthoses and the research and how that's supposed to work. And we'll also discuss some orthotic options as well. So much of the literature that's out there has pretty much just been spurred on by the sports community. So anything really before the 1970s, knee pain was pretty much considered to be just the result of arthritis or trauma. So foot motion wasn't really considered to be part of it, or certainly not a causative factor. There's lots of literature out there now to help us try and understand the pathomechanics of knee pain in relation to what the foot's doing. And then obviously the role of the foot, role of foot orthoses rather, has an effect on that too. So one thing I will say before we go too far is that not all knee pain is foot related, and therefore not all knee pain can be treated by orthoses. So it's the same old thing that I say every time. Some things work for some people but not necessarily for others, but we'll talk about that as we go through. So. Okay, so a little bit of a review here of our anatomy. So this is quite a nice simple picture, and we're looking at the front or the anterior view of the knee. It's also quite a nice picture if you want to print it out and have it in clinic to show patients as well, because that helps them understand. So you can see the lateral collateral ligament. The medial collateral ligament is on there the other side as well, but obviously that's not marked. You can see the meniscus, shows the fibula, tibia, patella. You can see the ACL or anterior cruciate ligament, and the PCL, posterior cruciate ligament, will be sitting behind that. And then you've got the cartilage and the femur on there as well. So a bit more depth in this one. We can see the superficial layer, and this is both the front and the back of the knee. And in this you can see a few extra bits in there as well. So the retinicular, the fat pad, and the bursa on there too. So again, quite nice pictures if you've got patients coming in and you want something to help explain to them. Okay, so a little bit of a reminder here. Visually is always the best way, I think, to remember this one. So a bit about varus and valgus knee positions. So on the left-hand side there we've got the, and I say it in inverted commas, normal, our perfect knee if you like. And then we've got a varus knee position, which is bow-legged. Your valgus knee position, which tends to be knock-kneed. But one of the things I like about this picture is it actually, if you're looking closely at the knee joints, you can see quite nicely how the joint spaces close and open up on the medial and lateral sides, depending on whether it's varus or valgus. So if you look particularly at the middle picture there, the varus, so there's the bow legs, the John Wayne sort of style of position there. If you look in at the medial compartment of the knee, you can see it's pretty much bone on bone and you've got no joint space. Now that's quite pertinent when we come later on to talk about lateral posting and what we can do for medial knee OA. As I say, that picture shows it quite nicely. Okay, and then a little bit of a refresher here of the different planes, because we'll be talking about them a fair bit too. So the frontal plane biomechanics is thought to be affected by the femur and the Q angle proximally, and the position of the knee, either in verum or valgum. And this is where your lateral wedging comes in. Sagittal plane is the plane in which the knee is intended to function, so sort of flexing and extending and moving backwards and forwards. And then internal rotation of the tibia is what you see in the transverse plane, and this is thought to be affected by pronation at the subtalar joint. Right, now this is a nice simplistic diagram here, and one I've used for many years to explain to patients. But the thing is, the knee isn't that simplistic, and it's not always as simple as sticking an orthotic in and straightening everything up and realigning. So by all means use this picture to educate patients, and patient education can never be underestimated. Getting them on board with the treatment you're doing is something that should never ever be taken lightly. Now, what I will say from this picture is from personal experience, and I've had anterior knee pain when I was a sporty teenager. And I was diagnosed, I went to the doctor, goodness only knows how many times. My mother took me to the doctor, and I got diagnosed with everything from just being a teenager and just being that age and it being psychological, right through to it's an exotic insect bite. Now, I think that was in Guildford at the time, so I don't think they had too many exotic insects around there. But it just goes to show, and I've seen this in private practice as well, you get an awful lot of teenagers that go to the doctor because they've got painful knees or swelling on the knee or one knee or the other knee, and they tend to go all around the houses and they never sort of get the biomechanics addressed. Now, I certainly never had it resolved or addressed until I had my first year working in the NHS when I was working in a biomechanics clinic. And for me, I typically fitted into this diagram. So my foot excessively pronated, I got the internal rotation at the tib and the fib, my knee turned in, and my patella tracking went all over the place. So for me, it really was a simple case of sticking immediately pasted orthotic in, straightened it up, did a few strengthening exercises around the knee, and that was it. I've never had any knee problems again running. But it isn't that simple for everyone. But then having said that as well, I've seen quite a few teenage girls that has worked really, really well for, just because of the malalignment. As I say, it's not that simple for everyone, and the research does reflect that it's not that simple for everyone, but it's a nice analogy and a nice diagram nonetheless. So let's have a look at some common presentations. So this one is one we see quite often, so patellofemoral pain syndrome. Now, it can be multifactorial, but obviously we're focusing on the mechanics, the biomechanics. Now, there are various papers which connect the motion of the foot with what's going on at the knee. And if I mentioned all of them, I'd have goodness only knows how many slides here. So just pick the one by Ben O'Nig. And what he found was that the transverse motion of the leg and excessive frontal plane motion of the foot causes an abnormal coupling, which can result in the deterioration of the joint and inflammation, and that basically ends up leading to the pain that the people get. There's also various other studies that have linked patellofemoral pain to the foot posture index, and there's also a few studies suggesting that an increased Q angle is connected with patellofemoral pain, again because it interferes with the alignment. Now, there are countless more studies looking at this, the effects of foot orthoses, but the thing with the research is that often the type of device used varies greatly, and so do the methodologies. So it can be quite hard work sorting out your good research from your not so good. Also, the pathology of patellofemoral pain can be complex, and it also varies on a microscopic and macroscopic level. So my little picture I had beforehand that very simply said, oh, the leg turns in, pulls the kneecap out of joint, that causes the pain. Yes, it might be that simple in some people, but there are lots of other issues which could be going on. Now, Professor Sarah Curran gave an excellent presentation about this at Biomechanics Summer School this year, and she talked a lot about the different types of joint anatomy, nerve endings, the effect of the Hoffer's pad, vascular homeostasis, and that's just to name but a few, but all these things can end up having an effect on patellofemoral pain syndrome. So it's a common condition, but it can be challenging to manage. So if you have tried treating patients like this just with orthoses and strengthening exercises and it's not resolving, it might be worth looking into some of those other issues as well to see if they're playing a part. Okay, so with medial knee pain, typically speaking, and I'm simplifying this a little bit, strain or tractional forces occur at the ligaments of the knee joint, and they usually result from abnormal biomechanics in the frontal plane. So what this can do is it progresses to soft tissue overuse injury over a period of time, and that can then lead to changes in the actual joint, the makeup of the joint, and then lead on to sort of a degenerative osteoarthritis. Now, what can cause these biomechanical disturbances can be any one of a number of things, and I've mentioned a few of them there. So you've got joint malalignment, so that's like your varus or valgus knee position, previous injury, and again that's why it's always important to take a good history. Joint instability, so maybe you've got someone with ligament laxity. Increased knee loading. Now I've highlighted that because this has received a lot of attention in the literature, and also varus thrust. So all of those things can contribute to abnormal biomechanics. Now, one of the things, whether you agree with it or not, whether you've tried it or not, or whether it's still a little bit of a thing you're not too sure about, one of the things that's had a lot of interest in the research, especially with respect to medial knee arthritis, has been the knee adduction moment, or they call it CAM for short. And these are just a few papers. So one of them, the first one there, showed that an increased knee adduction moment increases the risk of osteoarthritis progression. Another one there said that the higher knee adduction moment is associated with the development of pain, but also the severity of that pain as well. And also the paper there associated or found that a greater knee adduction moment was associated with a varus malalignment. So that's again that typical bow-legged John Wayne type stance. Now there's just a few papers there. Some of them are quite old. There's lots of research on this. So if you get on your research, Google Research or Google Scholar or whatever other mediums you have for looking at research papers, look up knee adduction moment, and there's loads of really recent stuff on it, and there's some good stuff out there as well, so it is really interesting. So I always found it very hard to laterally post someone with medial knee OA, but after reading the papers and talking to people about it and also trying it as well, it now makes absolute perfect sense to me. But I do find when I talk to podiatrists, probably a third of them will say, yeah, that makes sense, I laterally post. A third of them will say, oh, crikey, no, I would never laterally post. And probably the other third are sort of sat on the fence in the middle, not really knowing what to do or whether they should do it or not. So if you're unsure, it's definitely worth reading up on, because there's some good stuff out there about it. Okay, right. Even if, I mean, you might be thinking at this point, well, you know, I'm watching this webinar, but I don't really treat knee pain. But you probably do see a lot of patients with medial knee OA, and it's highly prevalent in the population. So the Arthritis Research UK, when I looked it up last night, puts it at 18.2% of the UK population, which I didn't quite realise it was that much. And as I say, that's just knee arthritis. That's not osteoarthritis elsewhere. So there's a huge amount of the population that do suffer with this. And often these will be the patients that come in to see you with some other condition. And maybe you're picking this up as a secondary, or perhaps they've just put it down to, oh, I've got arthritis in the knees, there's nothing I can do. So some of the symptoms of this will be things like muscle weakness. I might get swelling around the medial side of the joint instability, stiffness, malalignment. That could all lead to things like impaired balance, and then reduced fitness as well. And then from the point of view of what happens to your patient, that leads to pain, which then leads to physical impairment. You can start seeing psychological or psychosocial issues, and then there's a link there with comorbidity as well. So it is one of those things, it might just be a little bit of medial knee pain, but that can have quite serious repercussions, especially in elderly patients, because if it stops them getting out, it stops them seeing people, it's got quite a knock-on effect as well. Actually, one of the best things you can advise for medial knee pain is exercise, but often because that helps strengthen the muscles and ligaments around the joint. But often patients can be reluctant to do this because it hurts. They think if it hurts, they shouldn't do anything, and then that kind of adds to the whole thing as well. So I've gone off on a bit of a side note there, but as I say, if you think you don't treat knees, I bet you after looking at that slide, you think actually there's quite a few patients I see that do fit that bill. So there are things that you can do to help them. Now, I'm not going to go into huge detail on this slide. It's more just touching on a few concepts, and we're sort of coming back to the biomechanics a little bit here. So generally speaking, the main orthotic goal for medial collateral ligament injuries and ACL, or anterior cruciate ligament injuries, is to limit the motion in the foot in order to address the tibial rotation. And basically that takes the strain and the stress off those structures. Now, obviously, there's lots of other interventions too, and that would make a whole new presentation, but it is worth mentioning. So if you're seeing sports patients, then this is something you need to look into more. But as I say, the main bread and butter patients that we see, it's probably the medial osteoarthritis, which is going to be the thing that we see most often. So let's have a look at a few of the papers here and see what they say, and see if it's just as simple as sticking an orthotic in and it helps the patient, makes the pain go away, or solves the problem. So this one here, this one focuses specifically on anterior knee pain, and looks at whether orthoses help in the short term rather than just doing nothing. So of course you get this argument as well, or is it just a placebo? You also, and I've had this before as well, you get other health professionals say, well, you know, there's this, that and the other paper that say that they don't work. But I would say for every paper that says they don't work, you could probably find a paper that say they do work, and this is where research can be quite conflicting. So this particular paper by Mills in 2011, it's based on outcome measures, and they found that using orthoses showed greater improvements. The only drawbacks with this paper were that the orthoses prescribed were based on comfort rather than actual biomechanical correction. And then in the conclusion of the paper, they didn't give any explanation as to how they thought the orthoses improved symptoms. So it's just a case of they'd given a moulded to the foot device. It helps symptoms, but they couldn't explain why. So there we go. Same old thing with orthoses, isn't it? We know they work. We don't know why. We're certainly with this paper anyway. Now this paper, again 2011, this looks specifically at knee pain in runners, 24 runners to be specific. And it was runners with a pronated foot and knee pain who experienced pain. And what they found with this is that by adding a medial wedge to an orthoses, gave relief while running on a treadmill for 60 minutes. So the follow-up was just 2 weeks. So it is kind of difficult to draw any long-term conclusions from this study. But with this study, the devices that they'd given were aiming to counteract the forces caused by excessive pronation rather than just giving a standard comfortable orthotic. So here we're looking at a medially posted device, and they found that it's alleviated pain on runners just for those 60 minutes while they're running. Barton, now he's a good chap to do some reading up on if you want to look at papers. So this one's specifically at patellofemoral pain. So the focus of this study was on pain reduction in a study of 60 patients with patellofemoral pain, and they were aged between 18 and 35. And the results showed that the orthoses give significant improvements, as you can see from the points I've put there. So number of pain-free steps down increased, single leg raises from sitting were easier, significant reductions in pain. But what was interesting about this paper is the authors hypothesized that the foot orthoses work by enhancing the afferent feedback from the cutaneous plantar receptors of the foot. So we're not changing eversion and inversion, we're not changing internal motion, we're not looking at the mechanics so much, but we're more looking at afferent feedback, which is something that's not been touched on quite so much in the research. And actually that's what they say at the end of the paper, actually, that there's an absence of research looking at the neuromotor effects of orthoses. So I personally think this is where a lot of the research is going to head in the future, and I think this is probably, I think they work a lot more by the neuromotor effects than we've given them credit for in the past. So, but it is yet another paper that has shown that orthoses work in terms of reducing pain, well, and also functionability there as well. Okay, another one on patellofemoral pain, and this is a very recent study, only this year in fact, by Mulgard. And interestingly with this one, it concentrates as well on foot exercises, so not just orthoses, but also strengthening those intrinsic muscles. So what they found is the addition of foot-targeted exercises and foot orthoses for 12 weeks was more effective than knee-targeted exercises alone in individuals with patellofemoral pain. So the effect was apparent after 4 months, but not significantly different after 12 months. So in that, I suppose you could say you don't know whether it's the foot exercises or whether it's the orthoses or a combination of the two. But I think that does highlight that foot strengthening exercises are an important thing to include as part of your treatment programs. And actually, as a side note, there's a lot of new research coming out about that as well. Okay, so this one, 2009, Eslami, looked at the kinematics aspect of orthotic intervention, and they looked at the changes in magnitude and timing when orthoses were used. And they found that foot orthoses could reduce rear foot eversion, which can be associated with the reduction of the knee adduction moment during the first 60% of stance phase during running. However, they also concluded that modifying rear foot and tibial motions during running could not be related to the reduction in ground reaction force. The other thing they noticed on there actually was that changes in magnitude and timing of rear foot eversion and tibial internal rotation by foot orthoses and their contributions to vertical ground reaction forces were not well understood. So we're always hearing that papers should be looking at the kinematics, and they've looked into this, but the findings they found is that as they don't understand it terribly well. So but it does show that with this one, the foot orthoses can change the kinematics. Now this one's a bit of a quandary. This is something I only learnt recently actually, because it's something I'd always thought was taken for gospel really. So patients with medial compartment osteoarthritis are more likely to have pronated feet. Now I've just put one paper there, but again tons of papers will back this up. But the question there is that causative or is it a compensation? So it's a bit of a chicken and egg scenario, and again I just assumed they had pronated feet, which led to the knee OA. Now what's been proposed, and Dr. Patterson brought this up again at Biomechanics Summer School, was that the foot possibly rotates to reduce the knee adduction moment, because with medial knee OA, if you reduce that knee adduction moment, which is what we saw on the previous slide, then you reduce the pain and the severity of pain and so on. So what not just him, but what a whole body of research or recent research is looking at is whether your foot naturally pronates to try and reduce that. So is the body trying to sort itself out? And again, if you're going to do that, would you then put a medial post in? And that raises a lot of other questions as well. So, of course, the other thing that comes from that is that if you do laterally post, would you then want to put an arch support underneath the foot? So there's no hard and fast answer to that. But as I say, that's something I learned recently, and it's sort of made me think differently about the foot pronating. And is the foot pronating a compensation rather than the foot pronating being a cause of other problems? And I think, depending on how long you've been qualified for, and I qualified in 2003, but certainly from then and going sort of before that, I think we're almost trained to think that pronation is bad, and pronation leads to all these other problems, knee pain obviously being one of them. And actually, after learning this, I've sort of realised that actually maybe it's caused by something else, and this is the body's natural ability to try and adapt. So, but what the answer is, I do not know. Okay, and that's really, I think, just a small reminder there in that slide, just to be critical of the research. So don't just read one paper and take it as the be-all and end-all. You need to sort of really read around the subject and see what the professionals and your peers are thinking about them as well. So, okay. So we know there's lots of research. We know it can be conflicting, but what can we do? Well, firstly, it's absolutely essential that you know the diagnosis and the pathology behind it. Now, it might be that you don't get it right first time and you might need to work on that, but for any diagnosis you make, and let's say that's not just with knee pain, that's with anything, you need to try and work out what's causing that, because that's what you're going to address. It's also important to remember that different device prescriptions are needed for different clinical presentations of knee pain. So it's not just always put a lateral post on for osteoarthritis and always put a medial post on for patellofemoral pain. Not that simple. And there's no point in me giving you a list of things that say this is what you should prescribe for knee pain, because it is multifactorial and there are many things you need to consider. So your choices will basically come down to what your patient has told you about their knee pain and what the biomechanical forces are which you think are contributing to the problem. So, and really from there you need to work backwards to come up with a solution. And you may find you try different things before you find something that works, and I've certainly done that as well. So, a little bit about material choices. And I say this because I do know people that always use medium density EVA, or they always use polypropylene, or they always use carbon fibre. But different materials have different stiffnesses, and different stiffnesses have different biomechanical effects. So depending on what you're trying to achieve is going to be dependent on the material that you choose. So stiffer materials generally will help transfer the direction of force you require. So if you really want to aggressively, I say, try and change the malalignment. We know we can't use that terminology now because it doesn't necessarily work like that for everyone. But if you use a soft material, it's going to squash. If you use a stiffer material, you're going to transfer those forces on easier. Also, I think with stiffer materials, the effect of forefoot posting. So if you're someone that likes to put forefoot posting on and you've used a flexible material, you're going to end up twisting the orthotic in the middle, and that's going to cause problems at the midfoot. Also, if you've got a patient that tends to get midfoot or mid-tarsal collapse as a result of their pronation, and you've used a flexible or soft material, that's going to collapse the shell. So in these instances, you need to be looking at stiffer material, even if maybe your patient's elderly, or even if at first point you think, oh no, I must use something soft. So always think about what you're trying to achieve with that orthotic. It's an interesting paper I happened to stumble across there by Frontal and his colleagues in 2008. And they found when they were looking at knee torque that softer or cushioned materials may increase knee torque during walking. So basically what they were suggesting with that is that can contribute to osteoarthritic pain. So you think it's quite tempting, isn't it, if you've got a patient that comes in and they've got a few issues and they've got medial knee pain and they're getting on a little bit and they're quite stiff. It's very tempting just to put a nice soft cushioning insole in because you think it'll feel, and it will feel nice and it'll feel softer to them, but actually are you increasing the knee torque as a result of that? So might not be with all people, but it is say worth considering what you're doing. And if they come back and their knee symptoms are worse, it may be worth thinking if that's the issue behind it. So I think the thing there is always be cautious about material choice. Know what your materials do and know what you're trying to achieve. And then that sort of brings me on to this one as well. So yeah, so just a few more thoughts on shelf stiffness there. So semi-rigid orthoses. Think about the weight of your patient and also about their supination resistance. This comes into the assessments that you do as well. So if you've got a very, very heavy patient and they excessively pronate, or they pronate with a lot of force or velocity or whatever term you want to give to it, if you give them a nice soft medium density EVA or a nice flexible material like top rail, it's going to deform very quickly under the load. Then on the flip side of that, you wouldn't give everyone a rigid orthosis because it may not be tolerated, especially if they've got limited range of motion in some of the joints in the foot. So lots of things to think about there. But as I say, definitely not a one size fits all when it comes to materials that you're prescribing. Okay, so lateral wedging. Now there's a growing body of evidence out there looking at lateral wedging, and I mentioned it a bit earlier. But even that's not straightforward. So the first paper up there, Shaw, suggests that a lateral wedge insole produces small reductions in knee adduction angles and external moments, but also a moderate increase in the ankle eversion rather. And what they say is that you should add an arch support to a laterally wedged device to minimise ankle eversion and to minimise adduction moments with that. So basically what they're saying is if you laterally post to change the position of the knee, you don't want to mess up the medial part of the foot. So if you put an arch support under there, you'll help support that. Now that conflicts what Dr. Patterson and Professor Bennell were saying at summer school this year, that the foot can naturally pronate to try and reduce the knee adduction moment. And some of us asked this question and we had a bit of a debate about lateral posting and what you should do and what you shouldn't, but generally speaking, the research now, and I'm talking about the really new stuff which has been done at the end of last year and the beginning of this year, is that you probably don't want to be putting an arch support on those devices. But again, I would say treat everyone completely as an individual and see what works best for them. And I think there's a lot to be said for trying it in the shoe and seeing how it feels, because your patient will soon tell you very, very quickly if it feels comfortable, if it feels odd, if it feels better, and all those sort of things. And I think if you put something in a shoe and a patient says it feels uncomfortable, I would be tempted not to tell them to go away and get on with it and break it in for an hour a day, 2 hours a day, 3 hours on the third day, and so on and so forth. So I think if they find it uncomfortable straight away, I'd be tempting to change it. So it might be something where you try an arch support, you try it without an arch support, you try different types of lateral wedging and see what feels comfortable for them. Because what your patient says is actually quite a good indicator of possibly what you need to do. Anyway, next paper there by Arnold. suggests that the ability of a lateral wedge insoles to attenuate structural changes may be dependent upon them being introduced to a subset of individuals rather than all people with medial knee OA. So what he's saying there is that it works for some people, but not others. What they do also say in that paper is that although if you did that, you'd be able to use it for a lot less people. If you think about the sheer number of people suffering with medial knee osteoarthritis, and there's an awful lot of patients who could benefit from having a little bit of lateral posting put on an insole. The last thing then, this is what I find really, really interesting, especially when looking at research, is that symptomatic findings are not always consistent with the biomechanical. So we're not really sure how that works, and it could be things like comfort, pain mechanisms, coexisting problems, and variable knee adduction moment responses between different individuals. But I think that's really, really important to remember when you are looking at papers that's especially some of the sort of kinematic ones that say, if you put a 5-degree wedge in, it changes this by this, or this is the effect on the knee adduction moment. What we've got to remember is that we're actually treating a real patient at the end of this, and sometimes we might prove all the biomechanical changes that can happen with a certain type of insole, but those biomechanical factors might not always tie in nicely with the symptomatic findings. So some people might have pain when they haven't got much of a knee adduction moment, others might have lots when they've got less, and there's all that kind of thing as well. So symptomatic and biomechanical findings do not always tie up. Okay, so if you are going to do lateral wedging and you want to have a little bit of a go, but you don't know where to start or what to do first, this is kind of the general advice. So wedge full length, so don't just stick a little rear foot post on, do it the whole length of the lateral side of the insole. Doesn't have to be anything fancy. You can just use something like a Bio Advanced in one of the different densities, and some of the strip wedging that you can get that comes by the yard. Trim it down and put it in place. The suggestion from the research is that if you post up to 6 degrees, this is enough to reduce the knee adduction moment at the knee. If you post over 8 degrees, it starts to then become uncomfortable. So as simple as that, really. You want to be posting sort of more or less between 6 and about 8 degrees. Anything more than 8 degrees is going to feel a little bit uncomfortable for those patients. Medial arch support, no answer to that one, unfortunately. So the thought behind it is that it protects the medial structures of the foot, because we know that putting a lateral post on will create more eversion at the ankle joint, but there's no evidence that putting a medial arch support in is going to protect that. Now, if you don't put a medial arch support, so if you've got just a really, really flat insole that you're putting in, what that would do is allow the foot to pronate naturally, and that would help to reduce the knee adduction moment too. So maybe that would work, maybe it won't. So the jury is still out on whether you need to medially support that insole. But as I said, until a couple of months ago, I would have said 100%, yep, you need a medial arch support. But now I'm not too sure until I've tried it on a few patients. Probably won't know. And there's just a few pictures there for you as well. So I don't know how clearly you can see that. So the top left picture just shows where it says B underneath, but you can see that's got a lateral support underneath the foot. And basically the only reason I put that on there is just to show how putting a lateral support in opens up that medial knee space compared to the picture on the left where the knee space was pretty much no knee space. And again, I've repeated the picture that we had in one of the first few slides looking at the varus knee. And you can see there's no gap in between the medial part of the knee joint there. So stick a lateral post in, address that knee adduction moment, and the idea is you basically push it in and open up that space, takes the pressure off, reduces the pain in simple terms. Okay, right, it stands to reason that if lateral posting works for medial knee OA, then medial posting should have the same principles to work for lateral osteoarthritis. And according to this paper here, which I found, yes, it does. But as far as I'm aware, there's no randomised control trials as yet to really look into this. There's tons of research looking at medial knee OA, not quite so much at lateral knee OA. But as I said, if you've got lateral knee OA, you wouldn't be putting a lateral post in, you might be trying a medial post on there. But again, might be something that you want to try it and see with those patients. Just a note on prefabs, there are hundreds on the market. If I'm obviously going to say that bios are the best, other people will say that others are the best. Sometimes you use the ones that your peers have used, the ones you used at uni, the ones you've used in NHS trusts. I think the main thing with them is whichever brand you tend to use is what you do to adapt them. A lot of them are heat moldable. You don't always have to use the additions that are in the pack. I think there's an awful lot you can do by having strips of wedging and semi-compressed felt and having a fiddle around and doing your own thing in clinic rather than being bound by these additions that came with this insole. This is what I must use. There's no constraints to that at all. Also, there's absolutely no harm trying a prefab before casting for a bespoke orthotic. And I think in pretty much all cases of knee pain that I've seen over the 15 odd years, I've always tried a prefab first to see how they get on, see if it's comfortable, see if it's helped before I've gone on to a casted. Not everyone would agree with me on that. A lot of people would say, no, I'm confident to know exactly what to prescribe to start with, and that's great. But as I say, for me, I think it's always better to try with a prefab first, because the trouble with patients as well is they forget to tell you stuff. So you think you've taken a very comprehensive history and you think you've pinpointed that diagnosis, you know exactly what the pathology is, and then at the end of it they throw a curveball in and tell you that, oh, actually they've fractured their fibula back in, I don't know, 1968, had loads of problems, and then suddenly that really changes what you're gonna do again. So right, we're nearly come to an end now. Now this has got absolutely nothing to do with foot orthoses, but I think it's really important. And I'm one of these people that hates addressing BMI and overweight. But this paper here showed that for every 1 kilogram in weight loss, the peak knee load reduces by 2.2 kilos. And I think that's kind of outstanding, really, and that's why I've put it there in bold and in red. So if you've got someone that's got high BMI and you're trying every single exercise, every strengthening, I don't know, you're doing ultrasound, you're doing foot orthoses, you're chucking everything at it, and they're excessively overweight, that's probably the prime factor in what's causing all the problems and what's going on. And when I worked in the NHS, it was also a lot of the problems that we saw, and we'd be addressing it, as I say, with foot orthoses, and actually what you really needed to do was just get them to lose a load of weight. So that's quite a nice, as I say, if you want to look that paper up, that's quite a nice quote there to hopefully inspire your patients to lose a bit of weight. Okay, so yeah, just come to the conclusion now. So your diagnoses and your differential diagnoses are essential, as is your patient history. And I remember a orthopedic surgeon saying to me years ago that he could pretty much diagnose any form of knee pathology based on what the patient saw, what the patient told him. So before he'd even looked at the knee, he pretty much knew what he was dealing with just from what the patient said. And a lot of that was just asking the right questions about where the pain was, how it came on, what exacerbated it, and so on and so forth. So do listen to your patients. You may need to experiment with different approaches. So the medial post might work on someone and it might relate to the research that you've read and it might make perfect sense, but it might not work with that patient, in which case you need to try something else. And obviously don't forget your disciplinary team. Now, we've not touched, there's tons of other stuff you can do with knees, and I've not focused on that at all with this presentation. I've always been lucky enough to have a good knee physio at hand, so I don't tend to mess about and dabble with the stretching and strengthening exercises when I've got someone nearby who that is their forte. So if you are dealing with knees and you don't know a good knee physio, find one, because then you can do some sort of inter-referral. And know your anatomy. I think I say that at the end of every single conclusion, know your anatomy, because that's crucial to know what you're dealing with. The other thing that I haven't mentioned on there, and I think it's important to say, is that despite all the research, and I said this earlier, we know that biomechanical findings don't always tie up with symptomatic findings. So do bear that in mind if you're getting a bit of a taste for reading the research papers, that the two things don't always tie up. So, right, I think we're just about out of time now, so I do apologise, I haven't written all the references down, but either email me at heidi@lbgmedical.com or just email LBG from the email you already had, and I can send you those. Right, someone's just said, what would you recommend book-wise and research-wise to improve biomechanical knowledge and assessment? Val Massey, the Big Grey Book, is an excellent place to start, but some of it is a little bit outdated now. we, or LBG Medical, will be producing a new biomechanics book within the next few months, actually, and we're hoping to launch it at SOCAP. So again, we've got one at the moment, but a lot of it is a little bit outdated. So still sort of critical and relevant, because all the old root stuff is still pertinent to what we do today. But yeah, if you keep a lookout, we will be having a new biomechanics book at the Part 2 road shows. And actually, if you're keen to improve biomechanics knowledge and assessments, then I would get yourself booked on to one of those. Information's on our website, or if you're signed up, you get emails about it. But also, we will have a book coming out soon. Otherwise, Podiatry Arena is really good. There's lots of stuff comes up on there all the time, but you do have to sort of pick through what you want to know more about. When I first qualified, I just really wanted to find sort of the biomechanics Bible that gave me the answer to absolutely everything, and I've just learned over the years that there's no quick and easy way of doing it. You've just got to read around the subject and look at different things as well. There's not one book, there's not one research paper, and I think that's because there's lots of new stuff coming out all the time. Oh, that's interesting. Actually, someone said, would you recommend any orthotic help for a patient with EDS whose knees are so lax that during gait they move from varus to valgus, or would you go straight for devices such as a knee brace, physio referral? I think I'd definitely go for a physio referral with that. And one of my colleagues years ago that I worked with had a son with EDS, and he was treated with foot orthoses, but it was part of a whole bigger global management. Because if they're that lax, you want to be trying to controlling that at the knee as well. So if he's not seeing a physio or not looking at knee braces at the moment, I'd definitely get one on board. And then you'll probably find you'll be led by the physio as to what kind of orthotic you'll be putting in there. Somebody said, got a patient with knee pain, just lateral when descending stairs and cycling. Could this be patelloretinacular inflammation? Yeah, it could be. It could also be meniscal, especially if he's coming downstairs, because when you're coming downstairs and also when you're cycling, you're loading it. So it could be a meniscal problem there as well. Questions I'd be asking is, has he had any previous injury? Yeah, you want to be looking at, get his previous history, and also be doing some tests to stress the medial and lateral collateral ligaments, look at the meniscus, and see if that's causing any pain as well, and also sticking your finger in the joint space, seeing if that elicits pain. So there's quite a few differential diagnoses that could be part of that. I think as well, if you treat sporty patients and you work in a multidisciplinary practice, it's amazing how much you can learn from your physio, especially if they specialise in knees. They can be quite a good lead on that. If you don't really treat knee pain, I bet from now, hopefully after seeing that presentation, you'll realise that actually there's a lot of elderly patients that come in that've got medial knee arthritis that you'd never thought of looking for before. Question is whether you want to address that or leave them be. But I think as health professionals, if we could do something to help, we should be giving that advice, even if it's telling them to lose weight and do more exercise. There's lots of stuff out there, and again, if you look up Kay Patterson and Kim Bennell's work, if you look up some of their research, as I say, there's loads of things you can do where you're not messing about with orthotic intervention or not doing anything that you're not confident with, but there's lots of good advice that you could be giving those patients as a health professional to do with lifestyle choices, which would improve their symptoms, improve their pain, and then, as I say, get them going out more and improving the psychosocial side of things as well. So just some advice you give could have quite a good positive knock-on effect. And remember, what is it, 18% of people in the UK suffer with some degree of medial knee arthritis. So that's going to be a good fair chunk of your patients that come in and see you. So if you have any other questions, then do email in and I'll be happy to answer them. Right, okay, going to love you and leave you. Bye.